classroom environment, for which this presentation on a quick update on HIV testing and sexual health for foundation year doctors is mainly designed. My name is Kazim Adrobo. I'm the local sexual health consultant in Eastbourne for ESHT. So the topics I've chosen today are around clinical indicator conditions for HIV. And I know you've had teachings along the way, possibly from my colleague Jane Harris, but I know that's clearly as well been disrupted at times. We'll talk about why it's important to understand a little bit about what's happening with the HIV epidemic in the UK. We'll look at HIV testing and testing strategies and how to improve them. And I'll talk to you and remind you a bit about sexual history taking. Now, I do think these topics are important, and particularly around sexual history taking, because this really might be the last time you ever get the opportunity to be taught about sexual history taking before you go off and do whatever you're going to do next. And I'll try and clarify the reasons really for going through it in a relatively painstaking manner. I mean, even for any other fact that it turns up commonly issues around history taking that you can take away from in examination as environments. Right, so I don't know how this is going to work, but I want someone to tell me about this chest x-ray. So this is a real case, patient who I saw many years ago, so pre-COVID, let's bear that in mind. I was asked to see this patient who was fairly sick. And how would you describe this chest x-ray? You can use audio if you want. It might be the only way forward. Right, so is it normal or abnormal? If you start at the beginning.
Someone's put diffuse patchy changes, AP film with patient in poor position.
Okay, yeah, so
could mean very unwell.
Yeah, excellent. So those are the pulmonary abnormalities that are very clear cut, and one would need to formulate a differential diagnosis quite rapidly for these types of interstitial changes in the lungs. So I'd like you all to give me a couple. Okay, so as I thought, this session is not going to work brilliantly because in the classroom, I'd point my finger at you and you'd have to answer the question. So we'll probably skip through it relatively quickly then. So yeah, I think in a clinical environment, in an examination environment, you'll be shown many x-rays of interstitial lung shadowing, and you need to think about differential diagnostic dustbins. And obviously at the top of your mind, you're going to think about infection. And then you can break that down into individual infections, maybe starting with typical or atypical. And then there are the broad categories, thinking malignancy, so you'd say primary or secondaries, conditions such as autoimmune diseases. And don't forget medicines, okay, so don't forget drugs. Drugs are always a good cause for many, many abnormalities, including radiographic changes in the lungs that would fit with this. So my favorites that I always remembered for my exams were amiodarone and methotrexate, but you can take your pick as there are many indeed.
Someone's put PCP pulmonary edema.
Yes, absolutely. So within the differential, yeah, this could be heart failure, sort of alveolar soft shadowing would fit very nicely with PCP infection. So there are some bonus points to be picked up on this just this film, particularly in the skeleton. This is a 56-year-old woman. Anything coming through on the other side? What about that right humerus?
Well, he's got some area of hypodensity on the humeral head or neck there.
Yeah.
So the sharp, a bit, the contour is not normal.
It's not normal, is it? But yes, good. What about how? So audio does work, which is brilliant. So what about the length of that bone?
Short.
It's extremely short, isn't it?
Someone's put lytic lesions.
Yeah, I don't think they're lytic lesions around. I think the main abnormality is a very thick, sort of bendy bone, very short bone.
And osteopenia.
Not necessarily. I think the bone is fairly dense. So we're talking, this is an achondroplastic 56-year-old woman. Okay, and I think if you took time to think about how long that humerus is, it would all become clear. And now I can't advance my slide. Anita, I don't know why I've lost ability to present.
See if I can. I don't see. I can. Let me see if I can. I could do it, but I haven't got your presentation.
Okay, I'll stop and start again. The joys of this technology.
Hopefully going back to face very shortly.
Right. Okay. So it skipped ahead hundreds. All right. So this was a sad case of misdiagnosis of HIV infection. 56-year-old woman, as I mentioned, with achondroplasia, who had presented in and out of the hospital and in the community with repeated episodes of respiratory sepsis, and finally an unresolving case of respiratory sepsis that prompted this admission and a trip to ITU. The background of her presentation, she had significant weight loss. She'd actually been under the hematologist for 3 to nearly 4 years, been monitored for relative degrees of pancytopenia. And this was her latest count, relative neutrophilia, low white cell count overall, obviously, and a low platelet count. And they hadn't done much, including a bone marrow investigation because of the thickness, difficulty accessing her bones. Sadly, she died from pneumocystis, pneumonia, shortly after her admission, and a positive HIV test after the pneumocystis was diagnosed. So in terms of missed opportunity, you can go back maybe over a decade of missed opportunities to diagnose HIV in this unfortunate woman. So you will be aware, of course, of the clinical indicated diseases that guide HIV testing, and it's broken down by sort of disease area, if you like. So if you look at the top line row there, respiratory, on the left-hand column is AIDS-defining illnesses, where yes, the patient has got AIDS and obviously will have an HIV positive HIV test, most likely. So not everyone with tuberculosis has got AIDS, but it's an AIDS-defining illness. But many might have TB, particularly from in sub-Saharan Africa. And in the UK, most people with pneumocystis have got clearly some kind of immunodeficiency. The most common one would be HIV infection. In the right-hand side are conditions where the prevalence of HIV positive test is greater than 1 in 1,000. So I'll put a circle around bacterial pneumonia. Obviously, this is what we're dealing with here. If you've been admitted once with bacterial pneumonia, you have a more than 10 times a population average of having a positive HIV test, and more than once kind of then goes up exponentially. And she had 4 admissions with separate episodes of bacterial pneumonia. So you will be aware of the clinical indicator diseases, and I'll just simply skip through a few of the common presentations. But I think with this technology that we're using, again, I'll be asking questions and we'll see what happens. Thrombocytopenia is a relative indication for an HIV test. We've had a number of cases of people present with repeated episodes of prolonged thrombocytopenia to hematology, and for years, and finally the diagnosis is revealed as HIV. So we've done a lot of work with hematology about testing, having an algorithm that prompts testing for thrombocytopenia. In fact, any unexplained blood dyscrasia, an HIV test is indicated. And we did a recent audit that showed about 40% of people with thrombocytopenia have been tested routinely for HIV, which is a huge improvement of what used to happen in the past. All right, so you might present with this. So who would like to describe this type of rash? Or how would you describe it? Or what would be your differential diagnosis?
Almost looks like erythroderma.
Yeah, okay, so describe it first before going for a diagnosis. I think is best way to do it.
So sort of a diffuse erythematous, widespread rash. Looks, I can't quite tell if it looks raised or flat.
Yeah, so I
There's
think it's a
some
bit of a
very small
mixture.
patches of normal skin in between.
Yes, good. So absolutely erythroderma from whatever cause would be part of your differential diagnosis. What else would you put in your differential diagnosis? The big clue at the top there.
So I'd also think of any sort of kind of drug reaction.
Brilliant,
In
yes.
terms of infection, I'm not too sure, to be honest, at the moment.
Okay, so but good. So always think broadly whenever you're asked a question like this. So you're absolutely right. So first of all, describe the lesion that you see, then think broadly in terms of your diagnostic categories, dustbins as I call them. So drugs absolutely would always be there, and they're always reliable cause of most things. But yeah, so in terms of infectious diseases, all you then have to do is then try and just maybe finesse that down a little. Could this be bacterial? Could this be viral? But it'd be quite common. So it's very typical of a viral type of reaction, a viral rash. So you've all seen this type of rash before in your clinical practice. And if it's associated with other symptoms such as headache, myalgia, generalized lymphadenopathy, then maybe you're onto a winner there. So you're thinking this could be a viral infection. It could clearly be a bacterial. It could be another type of infectious presentation. But I think in the right context, we're thinking, certainly within this talk, we're thinking, could this be a possible HIV seroconversion illness? They're both pictures of HIV seroconversion illness. As you can see, the range of presentations is very broad. This is another HIV seroconversion illness, a maculopapular rash that's very diffuse and kind of scattered, and it's not really there, and you could really miss it quite easily. And therein lies one of the challenges in the early diagnosis of HIV, and why we rarely pick it up, is despite most patients having a glandular fever-like illness, most don't seek healthcare. And if they do seek healthcare, it could well be described as a viral rash with no investigations done. Some patients can be quite sick, including neurological symptoms. And obviously, there is going to be a differential diagnosis in relation to that rash. But when I've looked back at some of these cases that have subsequently presented to us with a positive test, you're seeing GP notes. I've seen GP notes that just literally say viral rash, and I've seen A&E notes that literally say viral rash. And then the patient turns up 5 or 6 years later with a CD4 count of 200 and PCP. Okay, so just going through our indicated diseases then, how would we describe these lesions? Again, with these sorts of questions, I always go for what color they are they raised, are they multiple?
raised red / purpley lesions becoming confluent in areas.
Yeah, good. Okay, so they are raised. It looks as though you could absolutely, definitely feel them. They're almost kind of big enough to be nodules. And differential diagnosis, or are you going to go for the diagnosis?
Looks in this kind of talk, it looks like a Kaposi sarcoma.
Good, excellent. So the other places to examine, apart from the whole skin, you look at the face, the oral mucosa, the palate, and the genitalia. There's something interesting about the palate in KS. Does anybody know the link? Why is it always useful to look in the palate? And if you see KS in the palate, you're going to order a specific investigation. Okay, you're going to order an endoscopy because they've invariably got it in the upper GI tract, particularly in the stomach, and there's a risk of hemorrhage if it's not treated. You might just see it presenting on the face or even just on the tip of the nose, and it can at times be a challenging diagnosis. Anyone know of any other purplish lesions that present on the tip of the nose? Connective tissue disease? It's something you've all heard of in the text way back in the day when you were at medical school: lupus pernio and sarcoidosis. Okay, so if you just look at the bottom picture there, if it was just that without the skin lesions, I think that would be strongly part of your differential diagnosis. But that is all KS. You may or may not know it's associated with human herpes viruses. Anybody know which number human herpes virus? It'll pop up in a horrible.
Is it 8 maybe?
It is 8. Well done. You can get quite marked edema with it if it infiltrates. That's another clinical sign. Okay, so KS is clearly in this context is AIDS defining. There's a subset of people who get KS, which is not related to HIV, but that's really unusual. So again, dermatology, those of you interested in it, you can't not be interested in dermatology because I think you'd struggle to practice clinically wherever you are. If you look at the indicators on the right, not the KS, you'll see conditions that are either severe or recurrent. You really should almost 100% definitely have an HIV test. Okay, so you can go ahead with confidence and say, well, there's a chance I've got HIV. There's a chance it's greater than 1 in 1,000, and it's indicated as per the NICE clinical guidance for HIV testing 2020. Okay, so a facial rash here. Again, these, I always want to update my slides because these haircuts and shirts are no longer particularly fashionable in 2021, but the rash remains the same, and it's a rash of we can describe it. Okay, so in this context, it's an itchy one. It's sort of flaky, looks a bit eczematous, a bit scaly, and of course it's seborrheic dermatitis, and it's associated with a kind of a yeasty organism called malassezia. We treat it with topical antifungal and low-strength steroid creams, but in somebody with very recurrent or recalcitrant seborrheic dermatitis, something as simple as that has an association with HIV infection, and an HIV test would be indicated. Okay, so what's happening here? We describe the lesions.
They almost look like sort of warty lesions.
Yeah, good. All right, so multiple warts on the face. Anything interesting about that? Do you often see multiple warts presenting on the face?
No.
No, good. When we normally get them genitals. So it can be a sign of significant immunodeficiency if you start getting warts on your face. So it's a good clue. There's another infection that one doesn't typically get on the face that cause that some skin to skin contact called molluscum. Again, you'd be all familiar with it. Molluscum, you shouldn't really get it on the face, or you shouldn't get giant molluscum anywhere in your body, really, unless perhaps you might be immunocompromised. And again, these are clear indications to have an HIV test. Okay, so this is a contrast CT with some positive findings. Anybody want to do a little bit of radiology? There are some very standout lesions to describe.
Ring contrast enhanced lesion with edemas around it that cause a shift of the cerebral.
Brilliant. So you got lost that lateral ventricle there, and absolutely a ring enhancing lesion. So as soon as you say that, your brain is thinking, right, I've got this brilliant differential diagnosis for ring enhancing lesions. So what have we all got?
Is that toxoplasmosis?
Yes, so very good. So a toxo type abscess. It is actually toxoplasmosis, but it could be a few other things as well. Okay, so again, I'm quite obsessive when it comes to trying to get you to start thinking about your diagnostic categories, and that will help you mainly spew these things out in exams. But there's a reason you learn these things, is in order to assist your clinical practice. Okay, so you go through that list again, think, right, could this be malignancy? Oh, yes, it probably could be a malignancy. Therefore, could it be a primary or secondary? Could it be some other form of infection? So could this be some form of bacterial abscess or any other kind of space occupying lesion? In this context, of course, of an HIV talk, would somebody present with headache, fever, confusion, focal neurology, and fits. With that lesion, it's clear it's cerebral toxoplasmosis. So within neurology, then the numerous AIDS-defining conditions where I think testing for HIV would actually occur. If you look to the right of that, though, interestingly, there's some softer things that you think, oh gosh, when's the last time we tested someone with Guillain-Barré with HIV? Again, that would be a very interesting audit. These things are associated again at that rate of one in 1,000. So it's cost effective in that context to do an HIV test, which only costs a few pounds, and you could clearly change the course of that person's prognosis. So yeah, viral infections causing scleral jaundice or body jaundice. They all hunt in packs. So if you're thinking HIV, if you're thinking this could be hepatitis B or C, then why on earth wouldn't you think of HIV at the same time? In terms of not HIV causing the hepatitis, but the risk factors are very similar, particularly obviously sexual contact or people who inject drugs. But there's also a kind of a counter argument in that people with HIV, particularly advanced HIV, can have a very fulminant acute hepatitis, and you really must make that diagnosis and stop the HIV if you're going to save that person's liver and life. Okay, so on to the testing guidance, which was updated in 2020. What do you need to know? Well, I guess the thresholds for what would be considered high prevalence have changed a bit. So we're in a high prevalence area. There is a higher tier than ours, a very high prevalence, which is more than 5 in 1,000. So we're nowhere near that in East Sussex. But however, it is indicated that we test everybody in MAU and A&E. And I don't know if any of you're probably a little bit too recent to have been involved in a HIV testing project that was occurring in MAU. Some of you may have been. That was largely unsuccessful in that the positivity rate was very low, but also for a variety of reasons, which I'll mention probably a bit later, the uptake, which is mainly physician driven, was very low as well. Okay, so I've mentioned clinical indicator conditions. I've not gone through them all, but I've kind of touched in most directions, and I urge you to have a look at those and try to understand them, particularly when you rotate around into a different specialty area. You'll notice lots of patients who are not being tested according to NICE guidance, and you can score some brownie points there. So people who newly register in primary care should be tested for HIV in high prevalence areas. And I can firmly tell you that outside London, that simply doesn't happen. People at high risk of HIV, so men who have sex with men and transgendered individuals, particularly transgendered women, are high risk of HIV, as Black Africans because of exposure in countries of origin, but also exposure within their own communities in the countries they've moved to, people who inject drugs, sex workers, and as a category, there's prisoners as well. So we do in-reach into Lewis Prison, we do quite a lot of HIV testing in there. So opt-out HIV testing, you may have come across opt-out HIV testing in your practice. Does anyone know where it works particularly well? Been operating in a particular part of the hospital for about 25 years, extremely successfully. Any guesses? In antenatal care. So at 12 weeks, all mothers get an HIV test. It's an opt-out test. They're not told explicitly you are having an HIV test. They're usually given a leaflet saying, these are the tests you've had today. Can we take some blood? This way we eliminate bias and clinician stigma, which are huge issues when it comes to who to offer an HIV test. And we found this out when we did the MAU pilot, in that on the ward round, despite it's meant to be opt-out, it was clear that whoever was pushing the trolley was looking carefully at the patient thinking, shall we or shall we not? Opt-out testing eliminates bias, and it's been shown to be acceptable to patients. Now, it's an area of misunderstanding. So we had really quite heated conversations, debates within the hospital about why the project failed. And some senior clinicians were really concerned that we were creating this ethical dilemma because we were testing outside the GMC guidance on informed consent. So I can absolutely reliably reassure you that opt-out testing is absolutely approved by the GMC, provided you are complying with information given. Okay, and information does not always have to be in a verbal format. You can give a leaflet, you can have big posters on the wall. So in places where it is a successful strategy with zero complaints, if you walked into the waiting areas, you would see lists everywhere of what you've been tested today. And people rarely read those and look up the HIV and say, you know what, I really don't want that HIV test today. But if you wanted to complete your satisfaction for GMC guidance in that patients should know what they're testing for, you just simply have to inform people they've been tested for HIV whilst you take their blood. That's all you need to do. Okay, so you should all be competent. I'm sure you are all competent in offering and discussing HIV testing, because you would have been taught this before. And you just need to know a little bit about the technology, not a lot about the technology. We're using so-called 4th generation HIV tests, which is your traditional venipuncture, so the ones that you request in the hospital. The window period is 45 days, so that's 6.5 weeks. And I think that's important that you know, because that's a recent upregulation, if you like, of the number of days between exposure and possible and your average seroconverted positive test. Okay, there was debate initially, could it be 21 days, 22 days, 3 weeks, etc. But the research is really quite firm. And it's worth remembering it's actually 6.5 weeks to be absolutely sure. The old-fashioned 3rd generation blood test is really not done in the UK anymore, but that is a 2-month, 60-day window period. And then you may have come across these commonly used tests, a point of care test that give you an answer within 10, 20 minutes. Initially, we thought these were going to be widespread of widespread value in emergency settings, but actually they get in the way because there's too much going on and nobody really wants to sit down for 10, 20 minutes while they do an HIV test, point of care test. You're better off just taking a venipuncture. So they don't really have much value in the hospital setting. They're more community based. And of course, within the community, most HIV testing now is self-sampling, where you take a capillary sample, send that off, or there are now tests that are licensed for home testing. So you take your own blood and you do your own HIV test, although that is far less common than self-sampling. Okay, so I'll move on then to updating you a little bit about what's happening with HIV in the UK, because it sort of really frames the testing bit and the clinical bit as you find out what is happening. And I suppose the first big dramatic issue, and I'm sure you'll be aware, is that HIV cases are plummeting. Okay, so from a peak of about 8,000 new cases a year in 2005, that has reduced by at least 50%. Okay, so we're now less than 4,000 new cases a year in 2019, and that is affecting all risk groups. So the biggest change has been that purpley brown line there since 2015 in men who have sex with men, but you can see all areas, all exposure categories, heterosexuals, men and women, are all reducing significantly. And this graph shows an estimated incidence with 95% intervals in the dots. And you can see that's dropped dramatically from about 2,500 new cases a year to just over 500. So what are the reasons this could be happening in the UK? Anybody have any idea?
So particularly for the men who have sex with men community, there's things like PrEP available now.
Very good. So PrEP is definitely making a contribution. I think if you examine the graph carefully, you'd see PrEP's only really been around maybe 2016, 17, and then more widely spread in 2018. And you can see it was already on the downturn significantly before then. Anybody have any idea why that could be? So, okay, we'll come to that. Okay, so I think this is the most important slide of all, or one of the most important slides of all. And this tells you how many people out there have got HIV and how many don't. So first of all, you might say, well, how do you know how many people don't have HIV? Well, there's some very clever Sentinel sampling sites in the UK. So these are areas dotted around the UK where if you have a blood test for any reason, any other reason, you have an HIV test. And in that way, it's unlinked to you as an individual. So even if that test is positive, you're not told about it. But it gives very accurate data of what is happening out there. So the total number of diagnosed people is just over 100,000. And that's roughly split between men who have sex with men and heterosexuals, Black African men and women, and non-Black African men and women. But if you look at the estimated range of undiagnosed people with HIV, the kind of the mean average is just over 6,500, with a range of 5,000 to nearly 10,000. Okay, so I mean, this figure I find just quite extraordinary. Okay, so if you think about it, in a population, out of a population of I don't know, 60 odd million people, we are looking for 6,500 people with undiagnosed HIV. Okay, which is an incredible concept to get your head around, because even if you looked at rare conditions and tried to get a definition of rare conditions, which is not easy to get, that's kind of less than 1 in 5,000, way than less than 1 in 5,000 people with undiagnosed HIV infection. Okay, so it's completely changed, obviously, the issue around how we screen for HIV and however being vigilant, because many places are thinking about dropping routine screening, say in MAU departments like ours, but you're still going to get people slipping through with those clinical indicator conditions. The main reason why HIV has been successfully controlled to a degree or is coming down, other than PrEP, is this concept of the continuum of HIV care. So the so-called UNAIDS targets at 90-90-90. So of the 105,000 people receiving antiretroviral with HIV, more than 90% of those are receiving antiretroviral therapy. More than 90% diagnosed, 90% on treatment, and more than 90% are virally suppressed. So the amount of circulating virus in the community that's available to infect individuals is dramatically reducing, or has dramatically reduced. So this is an important concept. It certainly pops up very commonly in our practice, but often we use it for people who are very reluctant to test or anxious about testing. They're anxious about how to discuss testing with somebody else, or they can't see the benefits of testing for HIV. So the U equals U, which is much easier to say than undetectable equals untransmittable. But it is the accurate concept that a person living with HIV who has an undetectable viral load does not transmit the virus to their partners. Okay, so I need to be in clinic in about 8 or 9 minutes. So I will just briefly run through sexual history taking, because I'm just going to go through some points. I won't ask too many questions here, although this session does work very well in the classroom, where you can break up into small groups and actually talk to one another. So why take a sexual history? Well, we're not being nosy. We want to assess clinical conditions, assess risk for STIs, including HIV, plan our tests. Do you remember, one of the cornerstones of STI management is we don't like to use syndromic antibiotic treatment. We like to make an accurate diagnosis and use the correct antibiotic. Clearly, we can identify other people at risk, so partner identification is really important in terms of infection control. You may not have thought about sexual health pathologies being linked to other areas, and they clearly are. They're everywhere. So huge field of anogenital cancer, subfertility, say the contribution of chlamydia to tubal infertility, neonatal infection, so not just HIV, but for example, there's been an increase in neonatal syphilis in the UK, unintended pregnancy, mental health. The mental health aspects are just huge, unresearched, poorly understood, but not just the impact, say, of the fear of HIV, but something as apparently benign as herpes is an independent risk factor for the development of depressive illnesses and anxiety. So what's different about a sexual history? Well, I think you'll all agree with these points that some people do it well, some people like to avoid it, some people hate talking about it, but it evokes a lot of emotive issues, embarrassment. It does involve talking about somebody else, etc. So they are very different. What concerns might a patient have if you bring up the suggestion about taking a sexual history? So what I used to find useful in the hospital context, because I do in-reach into the hospital, and you know that I'll notice a sexual history hasn't been taken, and they're used to having a completely different set of conversations with their doctors and nurses. And what I used to find useful is actually just to ask permission to change track a little bit and explain the reasons why you want to ask these questions. But people do worry about, obviously, confidentiality, and in the right clinical setting, you don't want to be taking a sexual history necessarily behind a flimsy curtain. People are concerned about being examined. In the outpatient's times, there are other concerns about sitting around with other people and waiting for ages in clinic. And then generically then, how can we make it easier to talk? You've been asked this question loads of times as an undergraduate, and you will be asked it as a postgraduate, but actually they are kind of useful reminders of what to say in an exam, but actually what to do clinically as well. Okay, I'll move on. In terms of the components of a sexual history, apart from the medical components, people often don't know what to say in terms of how to open the question. So once you've asked permission to move into a more personal arena of discussing something very personal, the easiest question is, when did you last have sexual contact? And some people, I think, who are non-GU trained often ask the question, are you sexually active? And I think that creates all sorts of confusion in the definition of active. So when did you last have sex is a better question. And then you can finesse where that, who that was with, not regular occasional partner, and you sort of do the tally over the last 3 months, including the type of sex. I'm sure you're familiar with that, but people are often a bit clunky on the opening two questions. So ask permission to take a sexual history, and then just simply ask them, when did you last have sexual contact or sexual intercourse, and then take it from there. Okay, to summarize today then. So HIV has not gone away, but is becoming rarer, very rare in some parts of the UK. The UK has got an ambitious program, and it is entitled, or the concept is no new infections by 2030, which, you know, seems radical and crazy, and it would have seemed utterly bonkers just a few years ago. But when you look at the projection of that graph we were seeing, we might not reach it, but we might not be very, very far away. So I mentioned before, keep clinically vigilant about the clinical indicators, because as HIV gets rarer, it becomes harder to find, and people might get sloppy around testing strategies or offering an HIV test, but the clinical indicators will occasionally pop up. Please be confident about taking sexual histories and use those two strategies in how to approach the patient about what to do in terms of moving on and asking that question, when did you last have sexual contact, and everything else will roll from there. And don't be afraid to request HIV tests. Okay, you don't need permission from anyone else in your team. If you see something that might be a clinical indicator, please put the test in. And that's me finished. Do you have any questions?
Could I ask a quick question about sort of new diagnosis?
Yes.
So when someone is diagnosed with HIV and started on the correct treatment, is there any particular time frame for sort of them to become undetectable, or does that vary person to person?
So it's a very good question. There are some independent parameters. The biggest one being the size of the viral load at baseline. Okay, so you may have a viral load, say, of a few thousand. You may have a viral load several logs higher. You may have it in the millions. If you got a viral load of a few thousand with modern antiretroviral therapy, you probably be undetectable within 2 weeks. But we've had patients with a viral load of 6 million who've taken almost a year to become undetectable. That's a relatively rare case. But modern antiretroviral therapy is super potent, and we're looking at people often being undetectable by 4 to 8 weeks. One caveat, though, about U equals U is that the data is only secure if you've been undetectable for more than 6 months after you started antiretroviral therapy. Are you uninfectious?
Thank you very much.
Is there anything else? Okay, fabulous. Thank you for your participation.